Good morning. I'm excited to kick it off. I'm representing Good Sam this morning. I want to talk about an issue that's been fairly recently relevant to all of us. So about using pigtail catheters to treat pleural effusions. And so here is the issue. I'm sure many of us are used to having IR around for procedural support. Here at Good Sam, at least, we've been traditionally able to utilize them for many procedures, including pleural effusions, whether they do a thoracentesis or pigtail catheter. But lately, staffing shortages all over the hospital have been making things very challenging. So they are not always as available as they used to, but do not fret. Not only have we been trained to do this, but we are more than capable of managing these patients right in the department. And so I just want to set the stage. Back in February, I had a patient. It was like an unusually slow Saturday afternoon. She was a 68-year-old female with a history of metastatic endometrial cancer who on baseline uses 3 liters of nasal cannula, and she presented with hypoxia. Her stats were initially about 70%, so her 3 liters. She was placed on high flow, initially did better. We were kind of working to get her admitted. And then, of course, right before placing the admission order, she complained of worsening shortness of breath, had worsening hypoxia. We knew what the issue was. I'll show you on the next slide, but we made a phone call. That day, IR was covering 4 hospitals and wouldn't be able to get to us for many hours. And so this is what her CT scan looked like. So you can see she had a massive left-sided pleural effusion. She also has a small one on the right. And so it was a moment where you decide we could either A, escalate her respiratory support, or B, try to solve the underlying issue. And so I just want to do a quick review on pleural effusions. There are 2 main types of pleural effusions. You have your exudative effusions, the majority of which are exudative, and they usually result from either peripneumonic effusions, empyema, or in the case of this patient that I'm discussing, a malignant pleural effusion. There's also a transudative set of effusions that are most commonly due to heart failure, renal and hepatic failure, or hypoproteinemia. Ultrasound is our ally when evaluating these fluid collections. So the way an effusion looks on ultrasound can give us a really good idea of what to expect when we attempt to drain it, whether we place a drain or do a thoracentesis. So in this image, you can see what seems to be an anechoic, very simple pleural effusion. And this could be either transudative or exudative, but it's a pretty simple fluid collection. Whereas in this image, you see septae and heterogeneity. So any degree of heterogeneity is pathognomonic of a complex effusion. So this is not a transudative effusion. This is going to be some type of exudative effusion. And while this is not a reason to not put a catheter in, you just know that you may encounter some increased issues when you're attempting to drain this fluid collection. So from our standpoint, what is the indication for draining a patient? And so overall, very broadly, to relieve effusion-related symptoms. So if a patient has refractory dyspnea, despite all this increasing respiratory support, diuresis or antibiotics if indicated, if this patient still looks like they're having increased worth of breathing or refractory hypoxia, you want to consider pulling the trigger. So I found this schematic and then couldn't even remember where I found it from, but it was a general overview of who to consider doing a thoracentesis versus a catheter. And so, of course, we're in the ED. We're only going to consider these for patients who are very symptomatic. It doesn't even so much matter what the etiology of their effusion is, but literature basically says if you think that you're going to end up draining over 1,500 cc's of fluid, then it's very worth leaving a catheter in. And I have in my reference slide some info on how you can calculate the size of effusion, but it doesn't so much matter. If you're in the ED and someone has a large effusion that's causing them respiratory compromise, it's a lot of fluid, and you're not going to be wrong if you place a pigtail. Kind of as I mentioned, there's not a ton of literature out there. This was the only article I could find in the EM literature about using pigtails for pleural effusions, but practically speaking, this is something that's done in the hospital by IR every day. So absolutely something we can handle. So I just want to give you a brief overview of the logistics, because let's be honest, most of us are very comfortable putting in a pigtail. We put them in all the time for pneumothoraces. But what you're going to want to do is you're going to want to use the ultrasound in real time to avoid the liver and or the spleen. You can do it either with the patient sitting upright if they can tolerate, in which case you'll put the tube posteriorly, or you can have the patient lying supine and you'll place the tube laterally. Literature says that you want to drain about 1,000 to 1,500 cc's of fluid at one time. Draining more than this in one sitting kind of increases your risk for re-expansion pulmonary edema or for a post-perfusion pneumothorax. After you get the tube in, you attach your pigtail to a pleural vac or a drainage bag and allow it to passively drain to water seal. You really only need a chest x-ray to confirm your placement. And very interestingly, for patients with these very large effusions, the tubes stay in for quite a while. So in the literature I saw, the tubes ended up staying in for 5 to 6 days. So if you're putting up this tube in the patient, don't even worry about you having to pull it. That's not going to be on you. That's going to be on the inpatient team. The question is, will you succeed? And the answer is yes. Depending on the literature that you look at, the success rates for successfully relieving symptoms in patients with symptomatic pleural effusions is somewhere between 72 and 90%. And as you could expect, your success rate is going to be highest in those patients with an anechoic pattern on ultrasound or these more simple fluid collections. And just as like a reference point, in the literature, success rates for pigtails and pneumothoraces was about 64%. So this is, we're used to doing pneumothoraces without hesitation, and they are overall less successful than draining these fluid collections. So we can absolutely handle this. You must always be aware of complications in these scenarios, but in all of the literature, there were no evidence of hollow organ perforation when ultrasound guidance was used. Complications that you can expect are pain requiring regular analgesia. If you even want to call that a complication, that just means you're going to have to treat the patient's pain. Pneumothoraces are only seen 2.8% of the time, infection 1.4% of the time, and even with exudative effusions, tube blockage only seen about 0.7% of the time. So my final slide is just a link for a video on kind of the procedure, a 14-minute long video on how to do the procedure, like prep the patient, lay the patient, ultrasound to do the procedure, and then a link to how to calculate the size of effusion if that's interesting to you. But the overall gist is this is something we can do, and we're going to have to be doing more and more, but we can do it. It's no problem.
So like the Dave said, we're going to chat about doing large volume paracentesis in the ED. And as is customary, at least in our residency presentations, we'll start with a roadmap. So we'll talk about why we should be doing this in the ER in the first place, how to actually do it very briefly, how much fluid we should remove, what to do about albumin, and what to do when your patient is a little bit coagulopathic, as might be expected in folks with some liver disease. So first question, why should we even bother doing this in the procedure, in the ED, right? This is what IR is for, except not so much, as Dr. Jordan pointed out, because of the staffing shortages. So let's say it's a busy Saturday, you pick up a patient who is scheduled for a large volume paracentesis as an outpatient next week, but they tell you, I'm just too uncomfortable, my belly's too big, I'm short of breath, I can't make it until my procedure is scheduled next week. What do? You can either try to admit them to a bed that may or may not be available and wait for the procedure, or you can get it taken care of in the ED. You can relieve the patient's symptoms, and you can maybe even avoid an unnecessary hospitalization where they would just be sitting and waiting for IR to show up. So how do you do this procedure? I'm not going to go into great detail as to how to do it because, as has been mentioned, we made a video about it. If I've done it right, the QR code on the screen should actually take you straight to the video. If not, I see the link in the chat, or if you want to, I guess, copy and paste off the slide, that also works as well. But the video is available on YouTube. If you just go to the MEP YouTube page, you can find it. And I'd like to think that it's fairly easy to follow, but toot my own horn a little bit. So now that you've decided to do this procedure, how much fluid do you remove? How do you know when to stop? The American Association for the Study of Liver Diseases and the British Society of Gastroenterology both recommend stopping at about 8 liters. That's the point when post-paracentesis circulatory dysfunction, so those fluid shifts, the hypotension, that kind of thing, that's the 8-liter mark is when the risk of that increases pretty significantly. I would argue that in our setting, our goal is to temporize the patients until they can get to IR or to whatever their next step is, and not necessarily to drain out every last drop of fluid they have. If they feel fantastic after you take 3 liters off, I think it's reasonable to stop there. If they're still feeling a bit short of breath as you're reaching the 7 or 7.5 liter mark, you can keep going, but I would stop at about 8 liters. Next question that often comes up is, what the heck do I do about albumin? I've heard this tossed around, give albumin in large volume paracentesis. Albumin is indicated when you're taking off more than 4 liters of fluid, and the dose is 6 to 8 grams per liter of fluid removed. And that's total fluid removed, not just the volume after 4 liters. So if you take off 5 liters, you're going to end up giving, for example, between 30 and 40 grams of albumin. And then I think the most common and potentially the most scary question that comes up is, yikes, I checked labs, my patient has an INR of 2 and their platelets are kind of crummy. Can I still safely do this procedure? And this is common, right, in patients with liver disease whose synthetic function is not fantastic. The great news is it actually doesn't really matter that much, and you can still do a large volume paracentesis. There are a couple of caveats that I'll touch on in a moment, though. The AASLD, American Association for Study of Liver Disease, and the British Society of Gastroenterology both actually have pretty strong recommendations that you don't even need to check the coags before doing this procedure, much less do anything about them. The direct quote from the British Society of Gastroenterology is that routine measurement of PT and platelet count before paracentesis and infusion of blood products are both not recommended, which they say is a strong recommendation based on moderate evidence. So it's a pretty beefy, you can feel okay about doing this procedure even if the coags aren't great. The caveat here is if there's some other reason other than the liver disease for the patient's coagulation ability to be compromised. So if they are uremic, if they're in DIC, that kind of thing, those would be things you would want to address prior to doing this procedure. I would argue, though, that both of those are sort of bigger fish to fry, maybe, than the ascites. And so these are not going to be the patients who are falling into the category of I can temporize this patient, drain them off, get them home if they're also in DIC. So just, bear in mind if it's purely liver related, you're okay to do the procedure. If there's something else going on, that might need to be addressed. And just to address some of the literature to back up the fact that this really is a safe procedure in coagulopathic patients, there are a couple of studies that I'll breeze through pretty quickly. So in 2009, Kheradi et al. Looked at risk of cutaneous bleeding in patients undergoing paracentesis and found that the risk is about less than 1%, including patients with an INR over 1.5 or platelets under 50. Grabow et al. In 2004 looked at 1,100 large volume paras in patients with a mean INR of 1.7 and a mean platelet count of 50 and found 0 significant complications. And then more recently, Rowley et al. In 2018 looked at 3,100 large volume paras in patients with a mean INR of 2.1, so even higher, and found that only 6 of them has post-procedure bleeding significant enough to require a transfusion. So all in all, even if the platelets are a little bit lower, the INR is a little bit high, this is absolutely something we can still safely do in the ED and should feel comfortable doing to help our patients feel a little bit better and take some of the strain off of our colleagues. That is all I have, and I'm happy to take any questions.
Thank you very much for the introduction, and we'll go ahead and get started. Let's see if I can get my slides there. And I apologize, there might be a little bit of background noise. They decided today we need to take a tree down in our backyard, and so sorry for the background noise. So just to put some numbers on things, how often are clinicians in the ED interrupted? So one study that we looked at was around 12.5 times per hour. I'm sure it feels like a lot more than that. Sometimes it does for me, sometimes a little bit less. And we know that those sources of interruptions can be staff, it can be technology like our phones, most of us aren't carrying pagers, patients, family members, people asking for directions, people asking for food trays. Depending on where you're located, there actually might be different interruptions. I spent time at a hospital center for 2 years, and then I went to Franklin Square for about 8 months, and then I was at Union again for the last 10 years or so. And I always found it interesting, the layout of the different facilities lended themselves to more interruptions or what shifts. Anyone at hospital center is certainly commiserated with being on the, I think it's been a long time since I've been there, but the red team where there was the EMS phone going off all the time, or is that the green team? That might be green. It's been a little while. But anyway, the EMS kind of radio going off and having to deal with that, or whatever traffic patterns. So anyway, we deal with interruptions a lot. And before I go on, I also want to make sure that I recognize Sharon Swencki from Union Memorial, who will be giving a talk a little bit later. She and I co-wrote, and really she was the one who brought me into this AAEM position statement on interruptions. So the link is down below, PDF, and really the goal for this talk was to kind of summarize that, but just definitely want to give her good credit as a co-author on this. So next piece is, why do we care about interruptions, right? Oh, obviously it's frustrating, but what are the impacts of those interruptions on just our kind of workflow and our well-being? So we've seen some evidence that interruptions can cause a risk of increased prescribing errors or ordering errors. We also know that can impact our ability to have situation awareness. What's going on in the ED? We might be focusing on an individual patient. Someone comes and interrupts us. We forget about that particular item that we were dealing with. And there's also a really high risk of not finishing the task that you were working on. So one study showed that about 18.5% of the time, we don't go back and finish what we were doing. So whether we were writing an order, we were documenting on a patient, we were doing something else, we don't go back about 20% of the time, 1 in 5 cases. And so we all probably pride ourselves as EM physicians and APPs that that we're multitaskers. We're used to talking on our phone. Everyone's probably doing that right now. You're reading your emails, whatever it is. But multitasking is a myth. That there is only one thing that our brain can focus on. And while there might be something going on, some music you're listening to, or conversation that you're kind of loosely aware of, really your brain is focused on that one primary task. And every time you switch between, and now I apologize, my dog is snoring on my lap. Every time you switch tasks from that primary task to that secondary task, whatever the interrupting thing coming in is, there's a risk. There's a risk you're not going to finish the initial task, that there's going to be a loss of efficiency, or you're going to make an error. So something to keep in mind. Don't ignore these issues because you think you're really good at multitasking, because you're not as good as you think you are. And that can be impacted by sleep, by stress. Lots of other environmental factors that are going around, not enough coffee maybe. All those things can impact our ability to deal with multiple tasks going on, and that switching between those tasks. There's also a link to well-being, increasing stress, and certainly the increased errors leading to moral injury and emotional trauma if we make a mistake. And across MEP over the years, we've seen a number of safety cases where patients have been harmed because of multitasking and interruptions. So what can we do about this? We can reduce the amount of interruptions that happen. We want to anticipate when these types of interruptions happen. We did a time motion study where research assistants were following us around and saw that a lot of interruptions happen when we go back to our desk. We are in the patient's room, we go sit down, and all of a sudden there's a line of people waiting to talk to us. So what can we do? We can write orders while we're in the patient's room. They can see that we're doing those things, and we can kind of take care of it before we're going to get interrupted. We can look at each of our centers and see when are we getting callbacks about critical errors. Maybe those are, we can reduce the number of times that we're interrupted because of, critical lab results. Are those necessary? And I know there's been some work in that place. We can also have a culture of being proactive and rounding. We can huddle with our charge nurses, our team, and say, hey, let's run the list together, not just running the list by ourselves, but running it with the rest of the team as well. And also, let's practice best behaviors and not interrupt others. I'm totally guilty of this, where I get really excited about something, an interesting case. I want someone to look over an x-ray with me, and I'll interrupt them while they're in the middle of writing an order. Let's be careful and mindful of our own activities. Second thing we can do is we can modify the types of interruptions that are happening. So let's try and do things that are less intrusive. So again, practicing on our own or asking other people, we can maybe use Microsoft Teams messages we're using with our hospital submissions. That helps cut down a number of phone calls coming in. We can write a note and either come back to it later ourselves, or we can leave a note for someone else. Again, there's some risks associated with that. We can kind of hover, right? We all kind of get a little irritated when people hover, but that gives a chance for us to stop what we're doing and take a moment to finish our task, and then address whoever's kind of hovering behind us. And then there's passive alerts. So instead of being interrupted constantly in EHR, can we use things like the smart zones or other types of alerts that let us know that we can get to it when the time is right? And then the third thing that we can do is we can try to mitigate the negative impact of those interruptions, right? So I mentioned this before, you can kind of ask to finish that primary task. So finish writing your repeat troponin or your morphine order before you stop to read the EKG. 30 seconds isn't going to make a big deal. 10 seconds most of the time we can get these tasks done. Take that moment to finish your task, because that critical moment, it's like the kind of Q on T in cardiology. If you get interrupted at the wrong time, the risk of you having an error is much, much higher, especially when you're writing an order. And that's that bottom part of the note. So be mindful, which is always a trigger word for me, but be mindful and aware of asking for a little bit more time. And then the last thing that I want to make note of is that not all interruptions are bad, that there's unintended consequences of reducing the interruptions, right? We don't want to put on the special hat saying like, don't interrupt me, or, a safety vest saying, don't interrupt me right now, because there's going to be unstable patients. There's going to be STEMI alerts that come in via EMS or via the EKGs. We want to make sure that we have an environment that supports interruptions when appropriate, and make sure that those staff feel comfortable with those interruptions, right? That we want to work as a team. We don't want to kind of go down someone's throat and yell at them if they interrupt on something that we don't think is appropriate. And we want to make sure that those nurses and techs are comfortable coming to us, because if they aren't, they're not going to come when there's a critical moment in time. So that being said, quick summary, interruptions happen frequently, plan to be interrupted, ask for times to finish your primary task, round with our staff, and don't interrupt others.
So hi there, I'm Sharon Swencki. I work at Union and at Harbor. So I know the last 2 years have been really hard for me. There were many times I thought I just wanted to walk off a shift. I thought I was burned out, but I really think that I'm here today to really convince you that that's moral injury and not really burnout. Imagine your average day, you walk into a VA hospital and find a PTSD support group, and you walk up to those veterans and you tell them that they're burned out. What would happen? You know, at Baltimore VA, you'd probably get punched in the face. But that is what society has told us as healthcare workers for many years. So in 1994, a VA psychiatrist named Shea really came up with the term moral injury to describe a syndrome that he saw in Vietnam vets. And then this was published in a landmark paper by Litz et al., VA psychiatrist in 2009, and really brought that to the forefront in military medicine. So moral injury was actually talked about by Euripides back in Hercules as well. The moral injury presents as shame, grief, spiritual and existential conflict, loss of trust with symptoms leading to depression and PTSD. Moral injury occurs when someone engages in, fails to prevent, and witnesses acts of conflict with their values and beliefs. What do we call healthcare providers these days? We call them frontline workers. So we basically compare them to soldiers on the front line. So it doesn't seem like that far of a stretch to extrapolate moral injury into healthcare workers. ZDogg MD really grabbed onto this in 2018 and put out this video really saying that we need to stop saying burnout. We need to call it what it is. And this is really how I sort of became aware of this. And it really made sense to me, which is why I wanted to present this today to you. Healthcare workers find themselves witnessing a great deal of suffering and death. The right tools oftentimes are lacking to provide the care that we want to provide. And this really leads to moral injury. Moral injury in healthcare is the result of a physician trying to serve their patient, but also to serve the numerous demands of the multiple stakeholders in modern day healthcare. And those are insurance companies and billing companies and healthcare systems, hospitals, productivity metrics, medical liability, and EMR. Moral injury in healthcare is knowing what care a patient needs and being unable to provide this care due to constraints beyond our control. So it is important to really separate moral injury from burnout. Because when we talk about burnout, we're talking about an individual. And this frames the individual as being deficient, lacking resources, lacking resilience to withstand their work environment. So now when we shift our mindset to moral injury, we talk about system failure. So this frames the problem as with the business framework of healthcare and the delivery of healthcare. It focuses on the separation of healthcare professionals from what we are trying to do. These things lead to depression, anxiety, and also suicide risk. Physicians are at a higher risk for suicide. Female professionals versus female physicians. Female physicians have a 400% higher rate of suicide than other female professionals. In 2020, in April of 2020, a New York emergency physician killed herself and is now considered a victim of the COVID-19 pandemic. So now let's look at the last 2.5 years of COVID pandemic. This added all new stressors. We had to worry about PPE and allocation of resources to our patients. We worried about staffing. We worried about getting ill and what would happen to us and what would happen to our family. We also lost faith in our communities. We saw our neighbors shun CDC advice on masking, quarantining, getting vaccinated. Well, we dealt with overcrowded emergency departments, rationing care, and we saw these critically ill patients. So just as in the military personnel, moral injury in healthcare workers can lead to depression, PTSD, just as we saw. So what can we do? We need to obviously there is really no answer. And of course, recognizing that this is a system issue does not make this any easier to resolve. It's clear that carts with snacks, fidgets, wellness retreats, meditation seminars, and pizza may boost morale in the short term, but they're definitely not an answer to the problems that cause moral injury in healthcare. One of the biggest things we can do is recognize that this is a problem, and we need to normalize and give support to our colleagues. We need to make it acceptable in our profession to seek help, and we need to find support. Now, the MEP Physician Concierge Service is available to all our providers, and this is a great way to find mental health support, but also to find support for other things in your life, such as childcare. We also need to come together with administrators and really work with them to change how healthcare is delivered and to change how we make decisions in healthcare about allocation and timing, those kind of things. We also need to come together in our departments as well as in our hospitals with other physicians and with healthcare workers to make a collegial environment. We need to make a community. And lastly, we also need to come together as a group and recognize that healthcare system needs to change and that we need to bring emphasis back to patient care, but also while recognizing the needs of our healthcare providers. And obviously, this is a task that is well beyond the scope of this talk and this 6 minutes.
Great. Okay, so my name's Paul Herman. I'm on staff at Montgomery Hospital, where the average patient age is probably 92. So this is a topic near and dear to my heart. I'm going to talk about identification and management of geriatric delirium in the emergency department. So a couple of quick objectives. So I'm going to go over evidence-based, so validated tools to be used in the emergency setting for the accurate identification of delirium. And then we're going to go over both non-pharmacologic and pharmacologic methods of management of delirium. So why does this matter? So I hope no one will argue with me that there are more old people, which means that there are more old people presenting to the emergency department, and old people are more likely to develop delirium both in the ER and in the hospital. Furthermore, as ED providers, we do a pretty poor job in identifying delirium. Some studies have suggested that we miss up to 80% of cases, and up to a quarter of patients over the age of 65 will develop delirium during their hospital stay. Not only is delirium associated with increased resource utilization, which I'm sure you can all imagine, sitters, nursing care, et cetera, but also worse patient outcomes, so increased mortality, longer hospital length of stay. So in terms of identifying it, so I'm going to go over a two-step algorithm that's evidence-based that uses first a screening test called the Delirium Triage Screen, followed by a confirmatory test, the BCAM, or Brief Confusion Assessment Method, in order to identify delirium in the emergency department. So the Delirium Triage Screen, it's a two-component assessment. It's been validated in the ER setting. It takes 20 seconds. It's 98% sensitive, so it's a great rule-out test. You start with a RASS, which is that sedation scale you might remember from residency in your ICU rotation. So if a patient is not RASS of 0, meaning not alert and calm, they screen positive and you move on to the confirmatory test. If they are alert and calm, then you move on to a test of inattention. So you have them spell the word lunch backwards. If both of these are negative, then delirium is ruled out. So studies have shown that this can reduce formal delirium assessments by up to 50%. If they screen positive, you move on to the confirmatory test, which has a specificity of 91 to 96%. So it's a little bit more involved. It's based on the CAM algorithm that's used in the ICU. It was specifically designed for and validated in the emergency setting. It takes like 1 to 2 minutes to complete and has 4 features. So first of all, you assess for altered mental status or a fluctuating course. This is usually assessed by speaking with the family or the caregiver. Just are they at their baseline? Do they wax and wane? Is there something going on? Then you go on to a test inattention, which you do by having them name the months of the year backwards from December to July. This is similar to the spelling lunch backwards, but it's different, so they can't cheat. Altered level of consciousness. So this is, again, your RASS scale. And then test for disorganized thinking using pretty standardized questions like, will a stone float on water? Are there fish in the sea, et cetera? It's slightly more involved than the delirium triage screen, but it's still very feasible to perform in the emergency department. Again, it takes like 1 to 2 minutes. All right, so your patient is delirious. So now the question is, what do you do? So first of all, I'm going to go over the most important things, which are actually non-pharmacologic. And this goes for both preventing delirium in the ER and also treating it if they have it. So there's 4 major groups here. We'll start off with adequate sensory stimulation. So this is like circadian lighting, a quiet room, minimizing unnecessary auditory stimulation like beeping cardiac monitors, intravenous infusion pumps, etc. Not always easy to do in the ER, but very important for this patient population. And then make sure they have their hearing aids. That's a big one that we always forget. Second is minimizing tethers. So this is important to me. So if they don't need to be on the cardiac monitor, don't put them on the cardiac monitor. If they don't need a pulse ox, don't put them on a pulse ox. Like these things that hook them up to the bed and hook them up to the machine, patients in that age group do not like, and they develop delirium because of it. Don't put in a Foley catheter if you don't need one. All right, so third is fostering orientation and reorientation. So this is frequent reorientation by nursing, easily visible clocks, calendars, encouraging family and friends at bedside, having familiar objects from home, and then consistency of caregivers, try to have the same nurse, the same tech, etc. And then finally, so ensuring adequate therapeutics. This just means controlling their pain, treat any electrolyte derangements you identify, any infections, UTIs, etc. And then nutrition. So, having adequate nutrition is good for patients, especially in this age group, and it's been shown to reduce the incidence of delirium. All right, so you tried all those things. Now you need meds. So first and foremost, you always offer PO medications, right, in any patient. So the preferred medications in this patient population are actually olanzapine and quetiapine, relatively low doses, as you can see here, 5 and 25. And then if you need to use Haldol, 1 to 2 milligrams PO is what you should start with. And then if those don't work or they, are not amenable to taking PO, you can consider IM medications. If your hospital has IM olanzapine, that's my favorite. There are fewer side effects when compared to Haldol. It actually has a faster onset of effect compared to Haldol. If your patient is at super high risk for extrapyramidal symptoms, like they have Parkinson's or Lewy body dementia or something, then you can try quetiapine instead of the antipsychotics. And then I hope you all know this, but avoid anticholinergics, avoid benzos in these patients. They do not do well with those types of medications. And just to prove I'm not making all this up, I put a couple of references here, but the biggest thing is this Cochrane review and multiple RCTs that I read showed that actually non-pharmacologic interventions are what were shown to be useful in actually preventing and treating delirium. Medications are just a temporizing measure. They don't really meaningfully change outcomes. So the take home here is that medications are an easy answer, but they're not always the right answer. So take home points, delirium is very common. We do a bad job in identifying it, and there's a whole host of data around like hypoactive delirium versus agitated delirium and which one we actually care about and which one we pay attention to. The DTS plus the BCAM is an ED validated method for identification of delirium. Non-pharmacologic interventions should always be tried. Do your best. I know it's hard in the emergency department, but if you need medications, olanzapine, quetiapine are the preferred agents. And that is all I got. These are my references.
Yeah, thanks for having me. So I'll dive right in. So I'm here to talk about how to do a disclosure after a patient has experienced a serious unanticipated outcome in their care. This is also known as our CANDOR program. It stands for Communication and Optimal Resolution, and it's been around within MedStar since about 2012. Okay. So we'll go over the who, what, where, when, why, how. The how, it needs a bit more discussion, so we'll go over the W's first. What is CANDOR? CANDOR falls within a communication and resolution program. That's what it is. Other health systems call them CRPs. We call ours CANDOR, and it is a principled approach for how a provider or a healthcare system responds to a patient having an unanticipated harm. Now, this is a foundational principle of MedStar as a high reliability organization. We do it because it's the right thing to do. It works to preserve the trust relationship between the provider or healthcare system and the patient and family, and it allows the opportunity for us to support the patient and family going forward past the harm. Now, this is a paradigm shift from the archaic system of deny and defend, and we've shifted to early communication with our patients and families after a harm event, with the goal to resolve it timely and to put into place any improvements within our system to prevent the same harm from happening in the future. Now, there is data to show that these CRPs, such as CANDOR, result in measurable changes in medical liability processes and outcomes. The article that's referenced at the bottom is a great article. I recommend reading it, but I will highlight that these CRPs will result or have resulted in increased safety reporting, transparency about harm events, and then event reviews or analyses, which previously have been called RCAs. They also result in decreased claims, lawsuits, legal fees, settlement amounts related to those claims or lawsuits, and then time to closure. So for a provider who might be named in a case, that means dealing with it, from 4 years down to 2.5 years. So that's pretty significant in terms of quality of life. Now, who can do these disclosures? Really, almost anybody, especially those who've been trained and are comfortable in doing it. So a provider can do it after discussion with risk management or quality and safety, a safety leader. As safety leaders, we've all been trained in this, other trained disclosure leads, and then of course in consultation with risk management or corporate claims. Now, preferably these are done in person, but in the time of COVID, a lot happens over the phone. So sometimes we do have to do phone disclosures, but we have to ensure that it's in a private and undisturbed setting, especially for the recipient of the call. Ideally, these communications are done within 60 minutes of the event, but it's just the first of many conversations. There will be ongoing communications as we learn what happened with the event. Now, the how. How do we do a disclosure? First and foremost, we identify a disclosure lead communicator. We identify the right time, place, setting for the recipient of the communication. And then within that conversation, we have to inform the patient or family that an adverse event may have occurred. But we reassure them that the organization will perform an in-depth review and analysis of the event to try to understand why it happened. That's called an event review. And for your own knowledge, it's not a peer review. This is a separate type of review. This doesn't critique judgment or evaluate, why certain decisions were made. Rather, it looks at how we delivered care, the process of care delivery. And it looks for opportunities of how we can improve our system and our modes of care delivery. The immediate priority is the patient's family, the patient's health going forward if they have any acute health needs, and then certainly the emotional and social needs that might come with any harm that's occurred. We reassure the patient and the family that communication will be ongoing. We provide a very clear point of contact that they can reach out to, a direct number. We don't want patients having to go through, phone tag or difficulty in reaching who they need to talk to. Now, an apology is recommended, but I just want you to be aware of some of the nuances with that. Maryland and DC do have apology statutes, as do most states, where an apology is not admissible as evidence of negligence or liability. So saying I'm sorry for what happened is recommended, is good to say. But if you think that you need to say, I'm sorry for what I did, that is admissible. So generally, it's worth talking to risk management prior to having a disclosure, but also offering an apology. Now, tips just to keep in mind, do not assume that the patient or the family knows what's happened. Only give facts. Do not speculate. Don't throw anybody under the bus. Keep in mind that you're just talking about the event in that distinct encounter. Don't be a disclosure lead if you yourself are distressed about the event. Keep in mind you need to be an active listener, be comfortable with silence and giving space to the family and the patient to react and respond. You might very well get an emotional response, and just be prepared for that. Anticipate they'll ask hard questions, anticipate that they might threaten to obtain a lawyer, but do not be intimidated by that. We actually recommend that, if they want a lawyer, they should get one. So I want to reassure our providers that MedStar claims management is on the provider side. So this is within our corporate policy that they handle all patient care related claims in a fair and equitable manner. And so they settle promptly and for a reasonable amount valid claims, and they defend vigorously frivolous and non-meritorious claims. And I've also experienced that firsthand. So if anybody wants to talk further about this, then I always welcome that. Any questions?
All right, great. Thanks, Dave. Well, good morning. So as Dave said, I'm going to talk to you this morning about anticoagulation reversal, and more specifically about reversal of the DOACs. This is now the most common reversal scenario we find ourselves in, and I believe definitely the most confusing. And we're going to try to take the bull by the horns this morning and embrace the confusion and hopefully come up with a little bit of guidance at the end. So reversal of anticoagulation is a core skill for emergency medicine clinicians. However, even at this point, I still often feel uncomfortable doing it. And I think this is because, the patient's on an anticoagulant for a very good reason, to prevent a stroke, to treat a pulmonary embolus. And so if I'm going to reverse that therapy, I better have a good reason for doing it, and I better know how to do it right. DOACs now being the most commonly prescribed anticoagulants, the world of anticoagulation reversal has become significantly more complicated. There are reversal agents with long names and large price tags, but professional societies, available clinical data, vocal experts on social media really don't always offer a consistent message on what strategy to take. So what are we as frontline clinicians supposed to do here when we have a bleeding patient on a DOAC? That is to make sure anticoagulation reversal is truly indicated. And in the ED, there are 3 reasons to reverse. First is that the patient is at risk of dying from blood loss. Second is that there is bleeding into a critical compartment. So think bleeding into the cranium, bleeding into the spinal column, the pericardium, the airway, maybe an eyeball. And then the last is the patient may not be bleeding at all, but they may need a truly emergent surgery that is not safe to do while the patient's anticoagulated. Once we've decided that anticoagulation reversal is indicated, how do we go about doing it? For reversal of warfarin, it's abundantly clear that rapid administration of 4-factor PCC and IV vitamin K is the way to go. But for DOAC reversal, things are much less clear. Broadly speaking, there are 2 main strategies. The first is to try to overwhelm the drug effect by repleting clotting factors, and the second is try to directly neutralize drug action with an antidote. Depletion of clotting factors is ideally done with prothrombin complex concentrates. FFP is inferior in this situation. And while there's a number of PCCs on the market, I'm going to focus on the 4-factor PCC, Kcentra, because that's what we most commonly use at MedStar. The question arises, does Kcentra work for the treatment of DOAC-related bleeding? And the answer is, we think so. The evidence of efficacy is limited to uncontrolled retrospective data that does seem to show adequate hemostasis in bleeding patients, and studies in healthy volunteers that does seem to show biochemical evidence of improved coagulation. If we believe Kcentra works, how do we dose it? Well, Kcentra is FDA approved only for warfarin reversal, and so traditionally for warfarin, the dose is based on the patient's weight and their INR. The heavier the patient and the higher the INR, the more Kcentra given. For DOACs, sort of no ideal dosing has been established, but often high dose weight-based is recommended of 50 units per kilogram. However, recent data suggests that Kcentra may be dosed at lower fixed doses for warfarin reversal to achieve similar reductions in INR and clinical hemostasis at reduced cost and quicker time to drug delivery. So this has led many health systems to wonder, could the same fixed dose approach be used for DOAC-related bleeding? The answer is maybe, but unfortunately the evidentiary support here is even more sparse. Observational data does seem to signal satisfactory hemostasis, but high-quality evidence is simply lacking. What about true reversal agents? Iduricizumab is a monoclonal antibody that binds to dabigatran, and andexanet alpha is a decoy receptor that binds 10A inhibitors. Things work. Well, they definitely work in vitro, but clinical studies of both drugs were limited in that they were single arm. There was no placebo and no comparator. The consensus is that they work, but we really don't know how well they work when compared with PCC administration. Relevant guidelines currently recommend iduricizumab as first line for the reversal of dabigatran, and guidelines are divided as to whether andexanet alpha is a clear first line for reversal of 10A inhibitors, or whether 4-factor PCC or andexanet alpha could be first line. 4-factor PCC is recommended either at fixed or weight-based dosing when direct antidotes are not available. So to summarize, DOAC reversal is a high-stakes clinical scenario. Treatment options are uniformly very expensive, and there's limited clinical evidence to guide our actions. So I ask again, what are we as frontline clinicians supposed to do here? At the end of my delving into this, I've come to the conclusion that it is best not to try to do this as a lone wolf. The best treatment approach is just not clear at this time. Weight-based PCC is reasonable. Fixed-dose PCC is reasonable. Direct antidotes are reasonable. I think the best way to do this is to decide as a group which treatment protocol makes sense. And I think fortunately for us at MedStar, there's a pretty big effort underway to develop a sensible protocol in the near future. As ED clinicians can really shine is in correctly identifying which patients will benefit from reversal and in providing good supportive care for the bleeding patient. It can be easy to get caught up in the complexities of reversal when what the patient really needs is source control of the bleed with direct pressure, surgery, endoscopy, or interventional radiology. Also important to keep in mind that as ED clinicians, we encounter the vast majority of anticoagulation-associated hemorrhages, and I believe that the responsibility for when and how to reverse does fall on our shoulders, and I also believe we're best qualified to make the call. Thank you very much.
Alrighty, thank you so much for having me. I'm not going to be talking about the little overdoses today. This is going to be the overdose where you're encountered with a huge bottle of verapamil and a suicide note. And if you don't remember anything else from this talk, I just want you to remember 3 things. Number 1, know your physiology. Number 2, let your echo guide you. And number 3, go big or go home. Okay. So diving right in, I think it's important to recognize that a lot of the times we can actually prevent toxicity from large beta blocker and calcium channel blockers in the first place through early and aggressive GI decontamination. So if you have a patient that comes in early presenting, you want to go ahead and lavage them. And there's very few indications now for which we do gastric lavage, but this is going to be one of them. And going back to the things to remember, you want to go big or go home because these pills are often very large and you need a 36 to 40 French tube to really properly lavage them. Once you're done lavaging them, you want to throw some activated charcoal down the tube. If they are too late to be lavaged, you want to go ahead and consider giving charcoal. And I encourage you to change your mindset a little bit about GI decontamination in these patients. I don't often ask myself, how long has it been since they overdosed? But do I think there's drug in the gut that I can get to? So even if they're beyond a couple of hours, they can often benefit from charcoal, particularly if they've taken a Costco-sized bottle of anything. So do consider late activated charcoal. And then if you have a patient with a sustained release product, you want to remember that you can do whole bowel irrigation. But what is important here is you need to watch their bowel sounds because as they get sick, they have poor perfusion to the gut, they get gut ischemia, and they have ileus, and particularly in patients that are on vasopressors. So your ability to properly decontaminate them will be much more limited as your patient gets sicker. The second thing I want to encourage you is to know your physiology. So regardless of whatever receptor pharmacology you learned for therapeutic dosing, it's really important to remember that all of that goes out the window when you're talking about a huge overdose. And the 3 things you're going to see are bradycardia, poor squeeze, and vasodilation. And one of the most common pitfalls I see in addressing these, and I review every death that gets called into my poison center, and I can tell you that these pitfalls are all from real cases. But you want to make sure that you're addressing all components of your shock and not just one. So pacing a patient that is profoundly vasodilated is not going to do any good. The other thing to help you determine your physiology and to help guide your therapy is you want to do a bedside echo early and often. Now, I am not an ultrasound person, and you don't have to be either. You just stick the probe on the heart, and if it's flopping like a fish out of water about to die, you can kind of get an idea that they have bad squeeze. The other thing I wanted to mention here is knowing your treatments and their limitations. So one of the first things we go to when patients are hypotensive is fluids. But in this case, they are not your friend, and I'll tell you why. Fluids, when you give to somebody with a sick heart at baseline, it's going to accumulate. If you have somebody that has a healthy heart but may get sick from a drug overdose, they also will develop fluid overload. And the other reason is that these patients are going to be on multiple drips. So they often end up profoundly fluid overloaded with pulmonary edema and on CRRT. So you don't want to do too much fluid. Atropine, don't care, don't expect it to work, but you can try it because it really doesn't hurt. One of the other things that I find has been a common pitfall is trying to pace these patients for two reasons. Number one, the pacer often doesn't capture. And number two, when it does, even if you pace the crap out of the heart, it's not going to do anything because you're going to be so vasodilated that you are not going to be able to mount a blood pressure. So don't let them take the patient to the cath lab to put in a pacer. Leave them in your ED or in your ICU where you can really resuscitate them. Other antidotes that we talk a lot about for beta blockers are glucagon. And once again, we're going to keep with our go big or go home, and calcium for calcium channel blocker overdoses. What I think is important to remember here is twofold. Number one, both of these agents develop significant tachyphylaxis. Number two, in massive overdoses, they can augment your other therapies, but they really don't do that much. So you're going to have to move on to your more advanced antidotes early. One thing I'm going to suggest is for the glucagon, they only come in 1 milligram vials. And if you have somebody on max doses, you're going to need over 200 vials for 24 hours. So you need to communicate with your pharmacy early to make sure that you have enough antidote on hand. Okay, on to insulin. This is one of my favorite things because everybody freaks out when I say give people 10 units per kilo per hour. But don't be afraid of high dose insulin. I can't tell you how many deaths I've reviewed myself where patients didn't get adequate dosing of insulin. And how it works is primarily by increasing your cardiac contractility. And this is why your bedside echo is so important. So if you put an echo probe on your patient, particularly a younger overdose, and they have a really good squeeze on their echo, that's not their primary problem. It may be more vasodilation. And in those cases, you want to go up on the vasopressors. Whereas if you look at the heart and it's really struggling, then you want to go up on your insulin. So know how to use your insulin. You do have to monitor the potassium and monitor the glucose while you're doing this. The other thing is the insulin drips, the standard ones are way too dilute and will cause fluid overload. So you need to remind your pharmacy to go ahead and concentrate your solutions. This is something I just already alluded to, but just driving the point home. If you have good squeeze on your heart, you're probably dealing with more vasodilatory shock, which is really common with these agents. So you want to add on pressors. The one thing that we do a little bit different here is methylene blue has been used as a salvage vasopressor, particularly in calcium channel blockers. So remember, if you've got good squeeze, dial up the pressors. What about lipid emulsion? So lipid emulsion came out a while ago and everybody thought it was the best thing ever and they were giving it to everybody and they thought, you know, this is great. There was tons of case reports where it was really helpful. But now that we have more data, we're really reevaluating that and we're not using it as much. Now, if your patient is in refractory shock, I don't think it's an unfair thing to give lipid emulsion, but with a couple of caveats. It works primarily as a lipid sink. It may help a little bit with ion channel modulation and as a myocardial fuel, but for the most part, it's a lipid sink. So if you don't have a lipophilic drug, i.e. propranolol, and you have a water-soluble drug like atenolol, it may not work as well. So you can try it, but don't be surprised if it doesn't work. It's also important to remember if you have a patient that's going to be going on ECMO that it does clog the filters. So if you give them lipids, they can still go on ECMO. You just can't run lipids while they're on ECMO. And lastly, the labs may be uninterpretable without being centrifuged due to the lipemic sample. So you may need to communicate that with your lab because these patients also need labs pretty frequently. Okay. On to ECMO. So think about it early. So in this case, we use VA ECMO. And once again, knowing your physiology is important. So if your patient has cardiogenic shock and has very poor squeeze, those are the people that are going to benefit the most from ECMO. If they have vasodilatory shock, ECMO is not as effective. I'm not saying that you don't talk to your colleagues about it, because often it's multifactorial, but just realize that it is going to be more helpful for patients with poor squeeze. Can you get rid of the drugs another way? Not really. So hemodialysis is limited for most of these agents because they're lipophilic and they have a large volume of distribution. There is a small number of beta blockers that are dialysable, but if you've ever tried to put somebody on 5 pressors on a dialysis circuit, we all know how that goes. So it's really limited as an option. But your patients may often need CRRT just due to the massive amount of fluid overload. The pro tip here is, if you think that your patient may need ECMO, go ahead and consider transfer early. So in short, I know this is a huge topic, but remember, early and aggressive decontamination, we are always happy to help you at the Poison Center. Communicate early and often with your pharmacy. Know your physiology and use your echo to guide which therapy. Consider early transfer and go big or go home.
Great. All right, let's go to the next slide. So sorry about the delay. So today I wanted to talk to you about occipital nerve blocks. This is something that I use pretty consistently in my sports medicine clinic for cervicogenic headache, occipital neuralgia. Sometimes I see refractory migraines sent to me. You know, I've started to transition it into my practice in the emergency department, because I think a lot of what we're seeing that's, you know, defined as a migraine, or they have a history of migraine, or they're refractory, or they're abortive therapies in at home, I think this may have a cervicogenic component to it. And, you know, this really stems from the greater occipital and lesser occipital nerves that come out of the cervical spine at the C1, C2, C3 levels, and they get inflammation from nerve impingement, especially with, you know, in the setting of arthritis or degenerative cervical spine issues. And what I notice is they often say, you know, I get my headache, it comes from right back here and it radiates like this. And when I hear that, I often think, does this have a cervicogenic nature to it? Now, obviously, you got to rule out the more emergent things as well. But if you do feel that this could have a more neuropathic or muscular component, it's something to consider. And these nerves will innervate the posterior aspect of the soft tissues of the neck and also the back of the skull. And that's why you get spasm and pulling on the nerve. We can go to the next one. And so this just shows some distribution of the kind of that pain distribution that they'll describe coming from kind of that mid soft tissue of the neck, and then it'll radiate up into the front of the head. They'll often complain of pain behind the eye. And I think that, you know, things like cluster headaches, tension headaches, just don't anchor and think, maybe potentially this is coming from the neck and has a cervicogenic nature. So we can go to the next slide. So I probably should have gotten a haircut before I took these pictures, but it did give me some insight on what the back of my head looks like. So this is a pretty easy procedure. You can do it both landmark based, I'd say a semi-ultrasound based, or just completely ultrasound based injection. But what you do is you're going to basically feel the back of the head at the occipital protuberance, and then you're going to feel where the mastoid process is. And you're going to draw a line between the two, and then you're just going to trisect that line. And the medial aspect of that line is going to contain the greater occipital nerve, and then the middle third is going to contain the greater occipital artery, and then the lateral third, you're going to have your lesser occipital nerve. So if we can go to the next slide. So here's a little next, go back one. So, you know, usually what you can do if you're not sure where the nerve and the artery are in relation to each other, oftentimes these patients are going to have pain when you palpate over those nerves. So just doing a landmark-based procedure by palpation is totally appropriate. But I do like to, if we want to go to the next slide, I like to do either directly inject under ultrasound, or you can do what I call templating. So you can take a look under ultrasound and you pick up where the greater occipital nerve is and where the occipital artery are, and you can just mark where each one is, and you don't necessarily have to see where your needle's going under direct ultrasound visualization. Now, I prefer to do that, but for some people, it is a little bit of a challenging procedure, and they'd like to have both hands available. So, doing the injection with one hand and holding the ultrasound probe can be difficult, but I think with all of our experience doing central lines, this isn't that difficult. But definitely something to consider. So things that you're going to need are, ultrasound is optional. I typically use an ultrasound in my clinic. I'd grab a 1 or 1.5 inch needle that's 25 gauge. 510 cc syringe, and then anesthetic of your choice. I actually like to do a combination of lidocaine and bupivacaine. The lidocaine has faster onset, but then the bupivacaine will last longer, which is kind of what the patient's looking for to help with the headache. And then additives that I use consistently are I'll use a steroid, either dexamethasone or triamcinolone, also known as Kenalog. And the dexamethasone is nice because if you're really in close proximity to the vasculature, which you are in these procedures, the dexamethasone or the Kenalog in theory can precipitate in the vessel. So dexamethasone, as we know, we use it intravenously all the time. So I typically use a dexamethasone additive. And then you can also, if you want, and this is a little fancy, you can do a little hydrodissection with some normal saline or some D5 if you're doing it under ultrasound. And then my favorite thing to do any kind of injection or aspiration is pain ease spray, which I find is just super helpful. You don't need to stick the patient twice by doing a lidocaine injection and then doing the actual procedure. If you inject right after you spray the pain ease spray, they usually don't even feel it, and it's bactericidal. So this procedure, like we talked about, you can do it bilaterally, you can do it unilaterally. Usually, again, what I do is I take a line and divide it by 3s from the occipital protuberance to the mastoid process. Again, medially, that medial section, you're gonna have the greater occipital nerve. That middle section is the artery, and then the lateral section is gonna be your lesser occipital nerve. I like to use, and I use this with all my injections or in aspirations where there's paracentesis or lumbar punctures. I actually like to mark I take an otoscope sheath and I just, with pressure, I just make a little mark, and I find that's really helpful. And because you use those surgical markers, and when you start cleaning things off, the mark typically disappears. So I like to use a pressure mark. And so I usually mark the different areas where the greater occipital nerve is, the artery, and the lesser occipital nerve. And then I'll use chlorhexidine scrub because the iodine scrub can, it gets in the patient's hair. They don't like it. It can stain the clothes. So I prefer chlorhexidine. And then what I'll do is I'll grab my needle. I'll insert at the areas where I've marked, and I'll usually go until I hit resistance, and that means you've hit the periosteum. I'll draw back about 1/2 centimeter while aspirating, making sure, standard technique, making sure we're not in the vasculature. And usually I'll inject about 2 cc's of anesthetic plus whatever else I've added in there, whether that's normal saline or steroid, and then I'll inject that at 2 locations. I'll typically fan around the nerve to kind of bathe it. And then I find this is kind of an important part, but you hold pressure and just kind of massage the anesthetic in there and really kind of disperse it around the nerve. And then usually what you find is within 5-10 minutes, the patient, if it really is cervicogenic in nature, it's an occipital neuralgia, the patient will say, my headache's gone. And you kind of saved them a migraine cocktail. You saved them potentially some pretty advanced imaging. Usually though, that'll last, 2-4 hours depending on what solution you're using. But if you do add a steroid, it's good to tell them that, the headache may come back, but the steroid typically kicks in 24 to 72 hours. It can really cool down that inflammation in the muscle and the nerve. And then I do encourage them to continue taking their home medications as needed. Now, things to look out for are just injection into a vein, artery, nerve. You don't want to hit the foramen magnum. That would probably be pretty bad. Infection, hematoma, allergic reaction. The one thing that you're not going to really have to consider in the emergency department is muscle atrophy. Usually that takes, that's something I see with multiple injections over time. If you are using steroid, that can start to degrade the muscle. I do have patients that come in very frequently to see me every 2-3 months for these. So it's something that we have a discussion about. So just to consider, basically the take-home points are to consider occipital nerve blocks in the ED, especially with kind of refractory headaches, or not everything that's described as a migraine is a migraine. But I like it for cervicogenic headache, tension headaches, refractory migraine. Bupivacaine and lidocaine are kind of the go-tos, and you can consider additives as needed. And then just familiarize yourself with that anatomy. Again, draw a line from the occipital protuberance to the mastoid process and divide by 3s. And then it's nerve, artery, nerve. That's it.